Think of a healthy human heart as a highly adaptive engine. It constantly adjusts both its stroke volume, the amount of blood ejected each beat, and its heart rate, seamlessly responding to whatever physical demands you throw at it. But that engine can suffer physical damage. A heart attack that kills off tissue, years of high blood pressure that stiffens the chamber walls, or a viral infection that weakens the muscle fibers can severely compromise its structure. The immediate result of this damage is a mechanical breakdown. The heart crosses a critical threshold where it can no longer maintain normal cardiac output, which is the total volume of blood it pumps per minute. When that total volume drops, oxygenated blood stops reaching vital organs in sufficient quantities, setting off a cascading biological crisis. The body is built to detect a drop in blood flow immediately. Pressure sensors in our arteries, called baroreceptors, and flow monitors in our kidneys trigger a system-wide alarm. But here is the problem. Those sensors are blind. They only know that pressure is low. They cannot tell that a damaged pump is the cause. From their perspective, a sudden drop in blood pressure means you are either bleeding out or severely dehydrated. Because the body misdiagnoses a failing heart as a massive fluid loss, it deploys evolutionary survival mechanisms to fix the pressure problem, mechanisms that end up targeting the exact wrong systems. The first survival mechanism is the sympathetic nervous system. It floods the body with adrenaline to force the heart to beat faster, a state called tachycardia, and to squeeze harder. Simultaneously, the kidneys activate a complex hormonal cascade known as the renin-angiotensin-aldosterone system, or RAS. This tells the kidneys to hoard salt and water, drastically increasing your total blood volume. This extra fluid increases what we call preload, the volume of blood filling the heart right before it beats. According to Starling's law of the heart, adding extra volume stretches the heart muscle fibers, creating a rubber band effect that temporarily forces a stronger contraction. But the RAS cascade also triggers widespread vasoconstriction, squeezing peripheral blood vessels across the body. This creates afterload, a massive increase in the resistance the heart must push against to get blood out of the chamber. In the short term, holding onto fluid and tightening blood vessels successfully restores blood pressure and keeps you alive. However, this temporary fix imposes a massive hidden mechanical cost on an already damaged heart. The damaged pump is now trapped. It has to work overtime to push a heavy burden of excess fluid against tight, resistant blood vessels. This flowchart outlines the exact physiological trap. At the bottom, decreased cardiac output triggers the adrenergic and renin-angiotensin systems. As we move up the diagram, those systems increase preload and afterload, driving up the heart's workload and causing direct myocyte, or muscle cell damage. Following the arrows back down from myocyte damage, the path leads straight back to decreased cardiac output. The heart weakens further, the body panics again, and the loop repeats itself. This illustration shows the physical consequences of that loop, a process called ventricular remodeling. Under chronic mechanical stress and continuous toxic hormone exposure, a normal heart physically changes shape. Over months, the muscle thins out and bloats into a dilated heart, severely impairing its ability to contract. The heart does have a built-in failsafe. As it stretches, it secretes proteins called B-type natriuretic peptides, or BNP, telling the kidneys to release the excess fluid. But these chemical distress signals are completely overwhelmed by the stronger RAAS hormones. The initial injury is no longer the main problem. The body's evolutionary attempts to save the heart have become the exact mechanism destroying it. You can see this internal cycle playing out in the patient's physical symptoms. As the failing pump struggles against high resistance, fluid backs up into the lungs, causing severe breathlessness, and pools in the legs and ankles as peripheral edema. For decades, the medical approach focused entirely on the pump. Doctors prescribed inotropic drugs, which chemically forced the failing heart muscle to beat harder, essentially mimicking the body's own adrenaline response. But whipping an exhausted horse doesn't make it healthy. Forcing a remodeling, failing heart to work even harder only accelerated the death of muscle cells and intensified the vicious cycle. True recovery doesn't come from encouraging the body's natural instincts. It comes from stopping them entirely. The modern treatment of heart failure ignores trying to fix the pump directly. Instead, we systematically block the body's false alarms to relieve the pressure. We use 4 distinct classes of medications: beta blockers, ACE inhibitors or ARNIs, aldosterone antagonists, and SGLT2 inhibitors. Together, these 4 pillars act as roadblocks, severing the harmful sympathetic and RAS feedback loops. This chart compares treatment timelines. Because the remodeling process is so destructive, modern clinical guidelines recommend rapid sequencing, shown on the right side of the diagram, where all 4 foundational drug classes are initiated simultaneously on day 1, rather than staggering them over months. Modern medicine treats heart failure as a complex neurohormonal cycle, rather than a simple mechanical breakdown. We silence the alarms, remove the resistance, and finally give the failing heart the space it needs to rest, repair, and survive.